So welcome back, everyone, and thank you so much for joining us today. I have the pleasure to be speaking with Dr. Jordan Emont. He happens to be one of the most successful, prominent OBGYNs on Instagram right now. So I couldn't wait to get him on the show so he can share with us all of his knowledge about cancer, menopause, insider information, and things of the nature. So welcome, Jason.
Thank you so much, Tiffany, for having me on the show. It's really great to be here. And I appreciate that warm introduction. I still kind of find myself in awe that I am where I am on Instagram after basically just a year, but I'm glad that my message has been salient for people.
Yes, absolutely. So why don't you talk a little bit about your platform? What did you get started with on your platform and Instagram, and what are some of your favorite topics these days?
Yeah, absolutely. So I really started my social media profile, I think, just from a personal love of education. It's
Mm,
always been something that I'm very passionate about. I think it's a big reason why I became a doctor, and I think a lot of what doctors do is they're educators, and
right.
we educate our patients. But I finished residency. I became an attending OBGYN, working as a generalist, and it became very abundantly clear how little I knew about menopause coming out of training.
Hmm.
And I found that to be very frustrating because
Hmm.
as soon as you start to take care of people, you realize this is what the vast majority of women want to talk about at some point. And so I really took it upon myself to, to learn and, to
Hmm.
really become a specialist in this. And I think the more and more that I learn and, I continue to practice, the more and more I've just realized how little knowledge there is about this, and maybe more importantly, how little high quality knowledge there is out there in this realm.
Sure.
And so I really started my page, I think, to be able to in some ways share the lessons that I was learning in real time, and be able to translate that for
Hmm.
everyone out there. But I think over time, what I've really come to be passionate about and,
Hmm.
and and care the most about is those groups of people that are often excluded from the menopause conversation. And I think that cancer survivors are probably, number one, two, and three on that list. There's a lot of excitement around menopause right now, but there's
Hmm.
so many groups of people who are told hormone therapy isn't for you, therefore you just have to suffer. Particularly for cancer survivors, I think there's a little bit of this narrative of you should just be grateful that you're alive. And I just completely, resent that idea. I think that all people deserve to have conversations on the quality of their life. And I
Right.
think that menopause is a huge part of having that conversation. And the education that I put out there is reflecting that.
Absolutely. And, I giggle not because I think that what you're doing isn't wonderful. It's just that, as you know, as a medical oncologist, part of my job is putting these poor women into menopause. And so, even as an oncologist, I have had a very upward um, learning curve in terms of management of menopause, because I think even on the oncology side, things are drastically changing and moving for the good, but there still is so much more to be shared and learned in the space.
Hmm.
And so, I think collaborations between people like you and myself are really important, because now we can have these conversations like, well, who's an absolute no? And is there an
Hmm.
absolute no? Or maybe there were some people that we were hiding, keeping away from the menopause treatment in the past, but now maybe it's a little bit more acceptable. So let's talk about some of those things as well. I mean, the obvious one is what? Vaginal estrogen, right?
Yeah, I mean, I think that that is the biggest opportunity for cancer survivors and breast cancer survivors in particular.
Hmm.
And unfortunately, it's still one of those areas that there needs to be a lot more education around it, both
Hmm.
for survivors but also for providers. And
Absolutely.
I don't even want to say necessarily just oncologists. I think that there's a lot of OBGYNs out there who are afraid of starting vaginal estrogen. They're still operating under this assumption that it's dangerous, it's going to make the cancer come back, it's an absolute no-no.
Right.
I think you and I are both on the same page, and for all the listeners out there, we can feel very confident in saying that we have very robust data at this stage, saying that people, even who have a history of estrogen receptor positive breast cancer, can very safely use vaginal estrogen. We know that vaginal estrogen is a very low dose. The absorption of that estradiol into the body is negligible, and is really zero over the long term. Everything is very locally acting. So that is already one concern that's off the table. And there's even a study, my favorite study out there about this, that looked at people who were actively undergoing treatment for breast cancer who were
Hmm.
using vaginal estrogen, and they actually had improved survival compared to those who
Yes.
didn't. And I think that a huge part of that is probably some combination of the fact that vaginal estrogen directly decreases the risk of urinary tract infections, which of course infections during cancer treatment can be a really huge impact on, not just quality of life, but even quantity of life.
Hmm.
Um, and then also that a lot of people are put on endocrine therapy after their initial breast cancer treatment,
Hmm.
and a lot of people discontinue that endocrine therapy because the side effects are so profound. One of those big side effects being the genitourinary changes that make it really uncomfortable, make it impossible to have sex with their partners. And so if we are able to provide some respite from that, it enables people to stay on that recommended oncologic treatment, which
Right.
is really, for me, such a huge area of collaboration between the menopause specialists and the oncologists.
No, absolutely. And I agree with you that we need to spread the knowledge and the wealth across more medical specialties because,
Mhm.
just you and I and the handful of people that are on, social media talking about vaginal estrogen, it's not enough. It's just not enough. And, every day I see patients now that are being refused the vaginal
Yeah.
estrogen or are themselves afraid to use it. They tell me that, I got the prescription, but I was afraid to use it. And
Yeah.
so I really do think that, there's a lot more public education is needed there for sure. So you want to talk a little bit about systemic estrogen replacement?
Yeah, absolutely. I mean, I think that this is really the hot topic right now. And I think that there's a lot of different areas that we can talk about with this.
Hmm.
The first and foremost, is you said earlier, are there any contraindications? Are there any areas where we would absolutely say no? And I
Right.
think that this is where there's probably going to be a big difference between the oncologist perspective and the menopause specialist perspective, and even among menopause specialists, depending on their comfort level.
Hmm.
I would love to hear your perspective as an oncologist on this,
Sure.
as well. Um, I think my perspective is really coming from just a baseline core belief that we as medical professionals, our job is to read the literature, to understand the science, to understand what we know, what we don't know, what's on the horizon, and then share that in an understandable way with our
Hmm.
patients.
Yeah.
I don't believe that it is our job to make decisions for patients about their own bodies. I think that the autonomy piece of the traditional areas of medical ethics, for me, is the absolute number one thing that we should be prioritizing as medical professionals. Now,
Hmm.
that needs to be within the constraints of true informed consent. And this is, I think, where there is a huge gap in this, because I think people are receiving a lot of misinformation. I think that people are not necessarily being properly informed about the actual gaps that exist in the knowledge.
Sure.
And and so because of that, people are going to get different opinions, they're going to get different ideas. And I
Right.
think that if you're not coming from a place of true informed consent, then I think that it's unethical to be using these tools. But just as an example,
Hmm.
I have patients who are breast cancer survivors, and are survivors of estrogen receptor positive breast cancer. And we have this conversation, and they talk about the side effects of the aromatase inhibitor that they're on, or even
Hmm.
they're past their endocrine therapy and they're now just, in kind of quote unquote normal menopause and still struggling with all of the same
Hmm.
things. And of course, we have a conversation about the non-hormonal options, which I think, is always a really important thing to discuss.
Hmm.
But I have patients who say, I understand that there may be an increased risk of recurrence, but that is okay with me because I am suffering so much.
Right. Right.
And I think that if we deprive people of that opportunity to have agency over their own body and be
Hmm.
able to make that informed decision of understanding the risks and the benefits of proceeding with any treatment course, I think that we are furthering the lack of bodily control that comes with a cancer diagnosis in the first place. And I think that it's really an important part of really acknowledging the humanity of what we do to enable people to make that decision. So I just wanted to lead with that, because I think
Hmm.
before we even get into the science of it, it's
Hmm.
just, for me, that is the real guiding principle of what I do as a medical professional. And
Hmm.
I have a feeling that you probably feel the same way, but I'm curious, kind of as an oncologist, how you think about that.
Well, I think, as you had pointed out, that unfortunately we're still lacking a lot of data and
Hmm.
there are specifically, areas where what seems to make sense and what seems to be reasonable, we really haven't proven yet. And
Yes.
so that's a very big problem. And so, there are definitely groups of patients that I think that it seems more than reasonable for them to have estrogen replacement therapy. And then there's some
Hmm.
others that I'm a little uncomfortable with it. I would never tell a patient that they can't have anything. And as you said, I agree with
Yeah.
you that, as long as you understand the risks and the benefits, then, you have to make your own decision. On the other hand, if I'm not particularly, because I will prescribe for my patients HRT if
Yeah.
they're appropriate for it. And I do give vaginal estrogen. I've been using it for years. At Sloan Kettering, we did a bunch of different trials. What was the other one? We used Femring. What was the
Hmm.
ring one? The ring one.
Yeah.
They
Like
and
for vaginal estrogen or for systemic?
for vaginal
Oh,
estrogen.
the
Yeah.
the estring. Yeah.
Yes.
Yeah.
And then, so we did a lot of those trials, and I'm pretty
Yeah.
comfortable with that. There are certain patients that they're in the heat of their estrogen deprivation, and that's their primary treatment.
Yes.
So, for example, the patient may have had, say, a low risk oncotype score, meaning that they didn't necessitate chemotherapy for their
Hmm.
treatment. And then, therefore, their treatment was basically the hormone therapy. And then to not take that, the patient is then choosing not to take treatment for their breast cancer. And so that's really tough. That's a tough
Hmm.
decision. And,
Yeah.
it is actually, Jordan, I think one of the things that's sometimes missed in this conversation is the fact that when you're talking to a young woman who is, yes, suffering with menopause symptoms, and look, I'm 57, I get it. I understand, from both sides of the table. But I think that the problem is that if you're talking to a young woman who had, say, a curable early
Hmm.
stage hormone receptor positive breast cancer, that say she was, didn't need chemotherapy, or say she did have chemotherapy, whatever, does she really understand what it means that the cancer comes back?
Mm, mm.
You know what
Yeah.
I'm saying? And again, I'm just playing devil's advocate
Yeah,
because I'm
totally.
saying that, if you haven't experienced recurrent or metastatic cancer, how do you know that that's really an okay choice for you? So
Yeah.
it's begging the question of what informed consent really is, I think. And so, and this is not a popular opinion, and I
Yeah.
know it's not something that I've heard a lot of the others that talk about this online discuss. But that's a real thing. That's a
Yeah.
real thing. What do you think about that?
I mean, I think it's a really excellent point, and I think it really actually brings up why I wish there was so much more collaboration between the menopause specialists and the oncologists, because I'm not an oncologist.
Hmm.
I don't treat people for their cancer.
Right.
I, of course, in my training have watched people experience, my training and in my career, I've watched people experience cancer, but I don't have that day-to-day experience of actually, telling somebody this is what happens when a recurrence happens. And I think that you're absolutely right. And that's why, in my perfect world, I think every major cancer center would have a whole team of menopause specialists. And when you get your diagnosis, you have your appointment with your oncologist and you have your
Hmm.
appointment with your menopause specialist, and you discuss all of these different perspectives. So that way you can
Hmm.
be going into it with a real understanding of, okay, what does this mean oncologically? What does this mean quality of life? And then, the other piece with the systemic estrogen, especially for a young person, is, okay, what does this mean for your other health consequences?
Hmm.
And
Of
so,
course. Sure.
we know that somebody who goes through early menopause has a significantly increased risk of cardiovascular disease and osteoporosis. And, this is, I think, another part of the equation that needs to be
Sure.
discussed. So I totally agree. I think that it's really an opportunity, and I think that it's really a way that we can collaborate a lot more. That being said,
Hmm.
um, I do always hesitate to kind of settle on these ideas of, well, this person doesn't really know, like they don't really get it. And the only reason that I say that is just that I think that medicine has a long history of telling women that they don't understand things and that they don't understand things about their own body. And I think that we always just need to be cautious with this idea um, of basically saying, that you won't get it, and you should trust me because I'm the doctor. Because I think that people have a lot of wisdom about their own experience, their own life
Hmm.
priorities. I think we even see this in a cancer diagnosis all the time, that
Mhm.
we're taught in medical school sort of the right way to break bad news, to tell somebody that they have cancer. And I think anybody who's actually been a part of those conversations will know that sometimes when you tell somebody that they have cancer, it's not the worst thing that's ever happened to them in their life. And we always prepare, for this idea of what that's going to be like, but maybe there's actually something completely different that's going on. And so again, I'm not belittling, the
Yeah.
meaningfulness of a cancer diagnosis,
Yeah.
or cancer recurrence, but I also think that we really need to trust people to understand, their own
Mhm.
expertise over their life, and kind of
Mhm.
and how that how they would prioritize that on an individual basis.
Yeah, no, I agree. I mean, I'm
Hmm.
bringing it up as a point, but not necessarily one that I would, you know, think that it's
Yeah.
necessarily correct for everyone.
Right.
But and being the doctor that has had to sit in the room with the 48-year-old woman and tell her that her breast cancer is now stage 4 and
Yeah.
has come back, I'm telling you, there's not much that can ever prepare a person for that. There
Yeah.
really isn't.
Absolutely.
And I just, it's one of those conversations that is the hardest. It's almost as that conversation and the conversation when there really isn't any more active treatment to
Hmm.
utilize for their cancer. Those two conversations in oncology are the ones that keep us up at night, and the
Oh
ones
yeah.
that, just I go, you go home and I can't even talk to my family because I'm
Oh
just
yeah.
so like I had to shut down. But yeah, so it's
Yeah.
a very nuanced conversation, and
Exactly.
this day and age, everyone needs as much information as they
Hmm.
can, and they need to, make their own decisions. I agree with you. I still think, what I think, what we really need here, and
Yeah.
I think about this all the time. I can't describe exactly what the test is, but we need a test in medical oncology. We have a couple of tests that we use for hormone receptor
Hmm.
positive cancers. One is the oncotype, and the
Hmm.
oncotype looks at whether or not chemotherapy would be additionally benefit in terms of
Hmm.
protection. And you get a score, and then you decide based on statistics whether or not the patient's going to take chemotherapy. And then a few years later, we have another test called BCI, breast cancer index. And
Hmm.
that test looks at the DNA slightly differently with a different algorithm, different genes, and can then predict what the likelihood is if the patient gets a second occurrence between years 5 and 10,
Hmm.
and helps you decide whether or not the patient should be on prolonged estrogen depletion. And it'll also tell you, these tests can tell you whether or not taking estrogen for those extra 5 years will help. So, for example, you could have somebody that the risk of it coming back in the last 5 to 10 years is high,
Hmm.
but then they can also have the result that taking further estrogen depletion will not help them. And so, that person, they don't have to take continued estrogen depletion, but they could potentially go on hormone replacement therapy, because that's telling me that the cancer is not hormonally driven, even though it's ER positive. So,
Right. Yeah.
I actually went back to the company about their test and asking whether or not we could validate in that genre, but I don't know. It seems like there's a lot more work that needs to be done in terms
Yeah.
of the algorithm. So, but that's what we need now. We really need to know who's really at risk and who's not.
Yeah. And I think we will get there, because I think this is an area
Yeah.
that people are really interested in. But I think that what you're bringing up is maybe the most important part of this conversation, which is that when we think about how people traditionally say these, absolute contraindications to hormone therapy, it's often just said a history of breast cancer. But
Right.
you and I both know that breast cancer is a million different diseases.
Right.
I mean, it's not even as simple as ER positive, HER2 positive or negative, whatever it is. We're actually talking about, even within the category
Yes.
of ER positive disease, there
Exactly.
are massive differences. And so I think that is where the really interesting nuance comes into the conversation. And
Hmm.
I totally agree. I would love if we were able to really start incorporating these tools that are really already being used by oncologists to then help guide how we have discussions about hormone therapy and the risks.
Hmm.
Um, and again, I think as an optimistic person, I'm very hopeful that we will get there. But I also know the state of women's health research in the world these days.
Or
So,
all research, actually.
exactly.
Like,
So we'll see.
right.
But but I think that what I'm excited about is I think the more and more that we open up this conversation, the
Mhm.
more and more that we have menopause specialists, we have general OBGYNs, we have maybe even especially oncologists being challenged with these questions from their
Mhm.
patients as they
Mhm.
learn. I think that it will kind of force the question, and I think it will force us into a position where people are going to really have to say, okay, it's no longer okay to just say no and say we're not even having the conversation. We actually need to get real data here, and we
Right.
need to fill those gaps so we can really guide people towards the best possible outcome.
Right, true. And but the problem is that, I mean, besides the fact that there's very little research that's actually being funded
Yeah.
right now, is the fact that the way that we've always done trials is not the way that we're going to answer this question.
Mm,
We're not going to be able to answer this question with, trials of, prospective trials following thousands of women
yeah.
either on or off HRT. We don't have time for that. And B, I think that those trials are so fraught with other problems in terms
Yes.
of there being inconsistencies in the data and inconsistencies in who was enrolled and what have you. Anyway, I yeah, we need to look at this whole problem from a completely
Hmm.
different perspective.
Yeah.
Somewhat, I liken this to something that's fascinating to me in the world of oncology. We use ctDNA, circulating tumor
Hmm.
DNA, and
Yeah.
for our audience, somebody that doesn't know what that is, tumor cells can release pieces of their DNA into the bloodstream, and it can be circulated and it could be removed and it could be measured. And we're now starting to incorporate either the presence or the absence of this positive cancer DNA in the blood work as to evidence as to whether or not the cancer is growing or shrinking. And it even allows us actually to change some of the therapies based on the gene profile in those cells. Anyway, but my point is that it's not ready for prime time, but
Hmm.
it came about really quickly.
Yeah.
It 5 years ago in oncology, I mean, ctDNA, I mean, it was a baby, and now it's being incorporated into major clinical trials at this point. And so you never know with the rate, if we ever get some funding back again, it could happen soon, because I
Yeah.
think that's really how we're going to answer these questions.
Yeah, and I agree, and I also feel like a lot of the ctDNA really actually came more out of a pharmaceutical lens, like kind of a private
Probably.
lens. So I feel like again there's challenges that poses, when it's not
Sure.
coming from maybe a little bit more altruistic of an organization, but I think that may be the gap, is that in this era where it's difficult to get any kind of formal research through, there may need to be some sort of commercial interest that actually establishes it.
Absolutely.
And I think that it's really easy to imagine that if some company, Natera, whatever these genetic testing companies are, develop some sort of test that could predict who would be a really great candidate for hormone therapy after their cancer, you can imagine that people would be very happy to spend that money,
Can you
and
imagine?
oncologists would be very happy to fund that. So I
Yeah.
think that it's an exciting world, and I think that it just brings up generally the idea that we should be welcoming all of these new technologies. We should be welcoming all of this data. I think that there's a lot of suspicion that inherently comes with pharma and commercial interest, but I think that actually a lot of great medical things that have happened have come from that world, and
Well,
it's just
they're the ones
it's
that have
just
the
providing
money.
more tools. Exactly, especially right now. So yeah.
So, well, we could go so many different
Yeah.
directions with this, but I have a burning question for you,
Yeah,
because
tell me.
something else that has come up frequently now that I'm seeing patients in a concierge manner is how to monitor
Mm.
when you're on hormone replacement therapy. So, A, do you draw estradiol levels? Do you measure the blood test? And B, even more complicated, what do you think about the urine tests that look at the breakdown products of estrogen? Do you think they have any meaning?
Yeah, I think these are great questions. So I think to answer your first I think to answer your first question, I do like to check levels. I even
Hmm.
do this for my non-cancer survivor patients,
Hmm.
for a couple reasons, but maybe very specifically in cancer survivors. I think that there is a lot of, again, coming back to kind of that bodily autonomy, and
Hmm.
an informed consent element. I think that there's something very empowering about knowing, okay, what is my estradiol level? Are we aiming for a particular goal? I think that where this especially comes up for people is when people are on an aromatase inhibitor and we are using testosterone, because of
Mm.
course a concern with the use of testosterone is this going to be converted via aromatase into estradiol. So for those who are listening, there is a protein that is largely in fat cells in the body, but in a number of cells that can actually turn testosterone into estradiol or estrone, so different forms of estrogen. And the concern is that if people are replacing testosterone and they have a history of an estrogen receptor positive breast cancer, that this may fuel that that growth or that recurrence. We could definitely get into the data surrounding testosterone because I think it's a really interesting frontier. But the data would say that actually at physiologic doses, we don't see increases in estradiol. But again, I think it's nice to do that check and show people that and show people, that we're not seeing that increase. The other reason that I like to check labs is because if we're thinking about one of the potential benefits of using hormone therapy, of not just being improving quality of life, but helping to reduce the risk of future consequences for cardiovascular disease or osteoporosis,
right,
we don't have 100% agreed upon levels that we should be aiming for. But I think particularly if we take the example of the 20-something-year-old patient who had an early ER-positive breast cancer, has been disease-free for many years, maybe even not on endocrine therapy anymore. That is somebody who we're much more worried about her long-term health consequences. And that's somebody who we're really going to want to make sure that we are actually reaching certain levels to be able to establish those benefits. I think I conventionally have in my head at least a level of 70 for estradiol. But again, those numbers are not traditionally agreed upon. So that's why I like to check labs. That being said, I still think that the number one argument to use hormone therapy is for symptomatic relief. I think that we have the best data on that, and I think that that is the clearest thing that people will feel. So I think if you're in a resource limited setting, if you are maybe part of an organization that is very, that really limits your ability to do that, which kind of depending on where you work might be the case. I don't think it's unreasonable to not check labs. And I think that that is also a fine approach. But I personally do like to check labs for those reasons. With regards to the urine testing and the Dutch test,
controversial topic, everybody.
Yes,
Here
I know. So I don't personally use Dutch tests. I'm also not maybe just in general, I'm not the kind of person that just shuns anything. I think that we should have an open mind with almost everything that exists in medicine. And I think particularly as you have brought up, patients will bring you these results. They may have gotten it with another provider. They kind of want you to weigh in. I think that it makes us look unprofessional and silly if we just say, this is stupid. Don't even worry about this. This isn't going to tell you anything. I don't necessarily think that the Dutch test, at least for me, provides additional benefit over serum testing. I think that, the thing that people will lean into is they will say, oh, but look, you can look at the metabolites and it breaks down into 2-OH estrone versus 4 versus 16. And, these have different pathways. And I think that, sure, it is nice to see that. And I think that there is interest in exploring what those different metabolites do. But we're not even remotely close with the research on actually showing that, these different metabolites or their ratios actually influence any sort of outcomes. Maybe we will get there. And this is why, again, I like to keep an open mind. But I don't think that we're at the point now to justify that. And again, particularly from the perspective of justice and equity, that's an expensive out-of-pocket test. And I don't think that we should be requiring people to do this type of testing that I don't feel like we have the data to 100% validate that it's actually going to influence any kind of breast cancer outcomes.
Very interesting. And I don't disagree with you. I'm a little bit on the fence. I think part of it is wishful thinking that it actually was clinically applicable because it is such an easy test to get and to actually you get very precise measurements. And the other thing, my other interest right now is the pharmacogenomics of all of this. And so, if you knew that you have a genetic change in the enzyme that converts it to the bad pathway, to the 4-OH pathway or something, would you take additional antioxidants or would you take, would you need some sort of a methionine,
DIM or something like that?
Something like that. And that, but I agree with you. We don't have the data to really support that. But since we don't have the data to support anything in terms of the estrogen metabolism, because we do know that some people become estrogen dominant and are
Right.
not right and
Hmm.
become unbalanced. Maybe we could talk about that a little bit.
Yeah.
What do you think about that estrogen dominance type of
Yeah.
a scenario?
I think in some ways I feel somewhat similarly that I think that there's a real phenomenon I think where people
Hmm.
will experience symptoms of having elevated estrogen, and I would almost say that there's also kind of a testosterone dominance picture that people can have, which maybe manifests as like a PCOS picture.
Right,
Um,
exactly.
and I do think that to some extent, there is
Right.
this element of it that is kind of the balance of certain hormones, and obviously there is something that goes along with that in terms of how that's being metabolized, how that's being processed in your
Hmm.
body, how it's being excreted and reabsorbed. Um, I think that we have to just be cautious with giving diagnoses, because I think that while I would always have the humility to say that conventional medicine does not know everything, and I
Hmm.
think that anybody who tells you that that is the case is wrong, and
Hmm.
I think we should be very open-minded to these other ideas.
Hmm.
Um, I again don't necessarily think that it leads us yet in a data-driven enough treatment
Hmm.
pathway to to then justify that diagnosis. If we're saying somebody has something, then we have to have a clear pathway of how we get out of that. And of course, there are going to be people that listen to this, and there's going to be, probably some naturopathic providers, who are going to say, this is what we do, and we do this, and we do that. And I have seen people improve in that way. So I don't in any way want to negate,
Hmm.
that is, I think, an appropriate choice. But I think that we just always need to be cautious, particularly when it comes to folks who are cancer survivors,
Yeah.
because we really just don't know. And
Right.
I think that I'm not the type of person to say we have to have perfect data to do something or anything. Obviously, I think I wouldn't be prescribing hormone therapy for cancer survivors if that was the case. But I
Hmm.
also think that we need to be cautious about overplaying our hand with the data that is available to us.
Yeah, no, I agree with you. I agree with you. And like I said, as I started when I asked you about the Dutch test, I think some of it, in terms of my optimism, is wishful thinking, because
Mhm.
we really, it would be so nice if we had these types of tests that we could really, counsel patients
Yeah.
appropriately based on, their blood tests, their urine tests, as well as their genomics, because we could predict so much. So,
And
um,
and and if I can just add one other thing, I
sure.
think that in terms of thinking about estrogen's effect on the body, I mean, we definitely know that estrogen we traditionally think about as being an anti-inflammatory hormone, but that
Hmm.
is actually not exclusively true. We
Hmm.
have different types of receptors in our
Hmm.
cells. We have estrogen
Hmm.
receptor alpha and estrogen receptor beta, and even saying as simple as, well, one is pro-inflammatory and one is anti-inflammatory is still simplistic, because in some tissues that can be a
Hmm.
pro-inflammatory pathway, in other tissues it could be an anti-inflammatory pathway, depending on the context that that cell is in, or even if it's been exposed to estrogen recently
Hmm.
or not. That can massively change how your cells are going to respond to that estrogen
Hmm.
stimulus. So again, I think that we just need to be humble with the fact that biology is. I think we need to be humble that biology is humbling. That we don't know
It's true, though.
everything. We don't know everything, and I think that the context matters. And so even thinking about decreasing somebody's future risk of breast cancer, either a recurrence or baseline, we know how much lifestyle impacts that risk. And
Yeah.
and and I deeply believe that it's overly simplistic to say, well, estrogen leads to breast cancer recurrence, or estrogen leads, to growth of breast cancer, when I think that that's going to be actually a very different story in, let's say, somebody who is metabolically very unhealthy versus somebody who is
Right.
not. So that context matters,
Right.
and
Right.
we can't pretend that we know everything and just say it's as simple as estrogen causes recurrence. Yeah.
Yeah. No, I agree. I agree. And it's, as we have mentioned, that there's so many different flavors and types of breast cancer that it's not a one size fits all, and it all requires a very nuanced conversation.
Yeah.
I personally think that it's not going to happen because we don't have any funding, but they need to start a new either subsection or residency program in
Yeah.
survivorship. There's
Yeah. I
survivorship,
oh,
and it could include
I love it.
menopause and the whole thing. I mean, this
Yes.
this is millions of people are walking around without true
I know.
guidance on how to survive after they've finished their treatments. And
100%.
I have to tell you, in a medical oncology profession, we're mandated to treat the sick ones, right? And so my healthy breast cancer patients were getting letters and sending them off to see somebody else after 2 to 3 years, and
Mhm.
they didn't like that at all, and I didn't like it. But on the other hand, there's only so much space for patients, and cancer keeps
Yeah.
happening.
Um,
Excuse me.
and I mean, it goes back to what I was saying earlier, that I think every major cancer center should have a menopause specialist in-house.
Mhm.
I think, again, I think that will change over time as more and more patients are demanding this, but I completely agree with what you said. I really think that cancer survivorship in and of itself is an art and is a specialty.
Mhm.
And there's so much that goes into that. And of course, every cancer is going to be different, and there's going to be different considerations. And, of course, men get cancer, and that's going to be a whole other part. So I think just need to be thoughtful about the fact that we are saving people's lives, who experience cancer. We have just the most impressive cancer treatments that are just getting better and better and more targeted as
Yeah.
time goes on. And even for breast cancer, I mean, survivorship for breast cancer is exceedingly high overall, and that wasn't even true, 50 years ago. And so
Right.
I think that now we have to ask the question of, okay, well, what happens to all of these survivors now? And especially as we have younger and younger people who have to
Yep.
spend the next, 60 years of their life alive, maybe facing other medical consequences. And
Yep.
so I think that my honest view is I think it's embarrassing for major cancer centers to not prioritize this, because I think that they, of course, they are doing their job and they
I
are,
just loaded the trucks.
advancing. Yeah,
Just
yeah.
loading the trucks.
But I think that, my personal view is I think that, cancer survivorship is equally as important as the cancer treatment, because now you save somebody's life. So now what is the life that you saved, and how do they preserve doing the things that they want to continue to do?
And that could be addressed on so many levels, psychosocially,
Yeah,
economically, even besides the physical component. Yeah, so this has been a great conversation. I'm going to have
I
you
agree.
back. We have to do this again.
I know
So
we didn't
I
even get into the science of all the, what we know and what we don't know about hormone therapy. I mean, there's so much more we can discuss, but I
definitely.
really think that the big picture, the 30,000-foot view of just how do we care about this, how do we get other medical professionals to care about this, and how do we educate patients is really where we start, because that's where the conversation starts, and then hopefully we have the science to go along from there.
Absolutely. So for everybody that can see the screen on YouTube, for example, I did put up the QR code to Dr. Emont's Substack, which is excellent. I have to tell you,
Thank you.
he's I don't subscribe to many, but I love his. And
Thank you.
really, you've had some great topics. He's covered a lot of oncology topics as well, and so I highly recommend following him, and me, of course. But I'm just plugging him for now. So we should write an article together.
Let's do
That'd
it.
be
I would
interesting.
love that.
That'd be
Yeah, yeah.
interesting. All
100%.
right, uh, we'll have to think about some topics for that. So,
Sounds good.
any last words?
This has just been such a fun, enlightening conversation, and I honestly, just going along with where we started this, that I think we're all always learning, and I know that I'm always learning, and I think that that's actually my favorite part of this job. And so, honestly, I don't always get a lot of opportunities to have a very open conversation with, an oncology specialist, and somebody who's truly an expert in this. So it's just been really fun. I feel like to share our shared wisdom.
Absolutely, and I feel exactly the same way, especially about somebody as esteemed as you are with your
Thank you.
menopause treatments. And so, yeah, to be continued for sure.
Absolutely, please.
Thank you again for being here. Bye, everyone. We'll see you soon. Take care.